Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from SOBI.
Anthony, now that I've examined your ankle, I can see that there's still significant synovial thickening and swelling, which explains the swelling and pain you're experiencing.
Yes, it's been difficult since I'm on my feet all day at work.
I'm sorry to hear that. I know the radiosynovectomy was uncomfortable for you as well.
Yes, it was quite painful, more than I expected. And now it's been several months and I'm not seeing the improvements we hoped for. It's actually been frustrating.
I understand your frustration. Your range of motion is also more limited than I'd like to see.
So, what do we do now? I'm not sure I want to do that same procedure again if it's not going to work.
We do have options to discuss. Typically, we would consider a second radiosynovectomy, as it can take 2 or 3 procedures to fully address the synovitis. However, given your experience with the first procedure and the limited response, I think we should discuss a surgical synovectomy instead.
Surgery. That sounds more serious.
It is a more invasive option, yes, but it can help when radiosynovectomy hasn't provided adequate relief. The surgeon would remove the inflamed synovial tissue directly, which can give better long-term results and help preserve your joint function.
I see.
For the surgery, we'll need to adjust your current therapy. Emicizumab alone won't provide sufficient coverage for a surgical procedure. We'll need to add factor VIII therapy before and after the operation to ensure proper hemostasis and wound healing.
I didn't really want to change my therapy.
I understand, but we'll discuss why your therapy has to change and what the plan would look like. But first, let me ask, how do you feel about moving forward with the surgical option? I know it's more than you were expecting.
I mean, if it means getting relief, finally, I think I'm willing to consider it.
Good. I think it's the best option. Now, let's talk through how to best manage your hemophilia through this procedure.
Hello, I'm Robert Klamroth, head of the Department of Internal Medicine at the Vivantes Hospital Friedrichshain in Berlin, Germany, and the director of the Hemophilia Treatment Center. The scene you just watched highlights one of the important issues in hemophilia care. Synovitis can still occur in patients receiving prophylaxis. And we have a higher rate than expected in patients on prophylaxis of synovitis, because we did a study in Germany with an ultrasound evaluation of joints, and there's synovial hypertrophy in more patients on prophylaxis than we expected. Synovitis can occur after any bleeding event, including traumatic bleeds, and if you have microbleeds or unrecognized bleeds, that can also lead to synovitis. And prophylaxis, which you usually protect against bleeding, in some cases cannot protect fully against synovitis. And we have acute synovitis, and usually if you treat the bleeding and the acute synovitis, everything is fine, but it can develop out of acute synovitis or after microbleeds, some kind of chronic synovitis. And these patients present with ongoing pain and swelling, limited range of motion, and it has a big impact on daily activities, quality of life, and all exercise activities. And in this case, we need a more intensive treatment. And then we have to discuss with the patients what would be your options to treat this more intensively. And one option is radiosynovectomy to treat the chronic inflammation in the synovia. And we typically would switch to factor 8 concentrates in this case to have a higher coverage or for this time to avoid any kind of bleeding. In this case, the patient chose to remain on emicizumab because he was quite content with his treatment. And of course, you have to include patient goals and preferences in this joint decision. And we educate patients on all therapeutic options. We gave our opinion, which might be or what might be beneficial. And in this case of radiosynaptectomy, it's possible to continue with imicizumab, but on the other hand, it's possible to switch to factor 8. This patient choose to stay on imicizumab, but we for sure need a treatment adjustment for surgery because imicizumab usually is not sufficient for surgical procedures, and we need to add factor 8 concentrate during and after the surgical procedure. Let's rejoin now the conversation as Dr. Müller explains to Anthony why a therapy needs to be adjusted and what this means for his treatment plan.
So you mentioned I need to add factor 8 for the surgery. Why is that? I thought the emicizumab was protecting me from bleeds.
That's a great question, and it's important to understand the difference. Emicizumab has been working well for you for everyday bleed prevention, but surgery requires a different level of hemostatic protection.
I'm not sure what you mean.
Emicizumab works by bringing together two clotting factors, factors 9 and 10, to help your blood clot. It mimics the function of factor 8 but does not replace it directly. Usually, it converts your severe hemophilia to mild hemophilia. For a surgical procedure, we need to normalize hemostasis to function optimally by replacing factor 8.
So there's a difference in how the clot forms?
Exactly. The clots formed when factor 8 in a physiological level is present have different structural properties. They're more stable and resilient, which is crucial during the surgery and healing process afterward. We need that extra stability to prevent bleeding during the operation and to ensure proper wound healing.
That makes sense. How long would I need to be on the factor 8?
We'll start factor 8 concentrate intravenous injections on the day of surgery to reach adequate levels. Then we'll continue it throughout your hospital stay and for the recovery period. Generally, we recommend an intensified factor 8 prophylaxis up to 3 months post-surgery to make sure the wound has completely healed and to avoid any rebleeding in this area.
3 months of IV injections? I have to admit, one of the reasons I liked emicizumab was how easy it was to get.
I completely understand that concern. We now have extended and ultra-long half-life factor 8 products, which means fewer injections than you might think, as infrequently as once a week. And this is temporary. We can discuss your long-term prophylaxis options once you've recovered.
Okay. That sounds reasonable. Thanks, Dr. Müller.
When planning surgery in patients with hemophilia, it's important to remember that non-factor therapies alone are usually insufficient to provide adequate hemostasis. While these agents are highly effective for routine bleed prevention, they do not fully replace the role of factor 8 in the surgical setting. So if we compare the mechanism of action between emicizumab and factor 8, you all know that emicizumab mimics the factor 8 function because it makes a bridge between factor 9A to activate factor 10. And usually with emicizumab, you convert severe hemophilia to mild hemophilia. But you all know that patients with mild hemophilia can bleed during surgical procedures, so additional factor 8 is necessary. Because only with factor 8 we can normalize hemostasis completely because we can reach normal levels, and normal levels are essential for a successful surgery without bleeding. And you can visualize this if you look at the different clot properties. Because if we have a full dose of factor 8, you have a normal coagulation and a normal stable clot with a normal clot structure. If we don't have the full normalizing of hemostasis, and with imicizumab we stay in the mild hemophilia range, the clot is not fully stable after surgery and bleeding can occur. So for hemostasis in surgery, it's critical to have a normal coagulation and a normal factor VIII. If we now do surgery, we usually start surgery to raise factor VIII immediately before surgery. You have normal levels during the procedure. And post-operative, for the healing period, it's important to maintain this high coverage, at least to complete wound healing. In case of joint surgery, sometimes we want to cover a longer period, and that can last up to 3 months after the full healing is settled. Several weeks have passed, and Anthony has successfully undergone surgical synovectomy. Let's join Dr. Miller as she discusses next steps and Anthony's long-term prophylaxis options.
Anthony, good morning. How are you feeling?
Much better, thankfully. The ankle feels different already, less of the constant pressure.
Excellent. The surgery went very well and the wound is healing nicely. We'll be discharging you later today, so I want to discuss your care plan moving forward.
Sounds good. I'm ready to get home.
For the next 3 months, I recommend that you continue with factor VIII prophylaxis. This will help ensure complete healing and, importantly, help prevent synovitis from developing in your other joints.
My other joints. Well, I've been thinking about that, actually. My right ankle has been feeling a bit achier lately. Nothing like the left one was, but still.
Exactly why we need to be proactive. Factor VIII will provide higher protection and help cool down any early inflammation in your other joints. After 3 months, we'll reassess and discuss our long-term prophylaxis strategy.
That sounds good. I will say the IV factor VIII injections haven't been too bad. What are my options after the 3 months?
We can consider several approaches based on what works best for you. You could switch back to emicizumab if you prefer the convenience of subcutaneous injections and less frequent dosing. But if you're doing well on factor VIII and want to continue, we have extended and ultra-long half-life options that require less frequent dosing.
I'm glad that I have choices that will fit my schedule. The kids are in so many activities. We're always running around.
Absolutely. We'll find what gives you the best protection while fitting your family and work life. For now, let's focus on your recovery. I'll have the physiotherapist come by before you leave to discuss your physical therapy.
Sounds good. Thank you, Dr. Mueller.
After surgery, it is strongly recommended continuing factor VIII until complete wound healing has occurred. We discussed already that for the surgical procedure, we need to normalize hemostasis. And for full wound healing and recovery, we need higher levels of protection and factor VIII during this period of time. And especially if we treat chronic synovitis by surgery, we want to avoid any kind of rebleeding and inflammation to cool down the joint. And in this case, imicizumab alone might not be sufficient because we cover only the mild hemophilia range and cannot normalize hemostasis. So in this period, microbleeds can still occur on imicizumab. And if microbleeds occur again, then we have a trigger when synovitis could be reoccur. So for the first period after surgery, high levels of factor VIII are important to have a full recovery after surgery. After this full recovery, and this period can last, depending on the wound healing, up to 3 months, we can discuss again the long-term prophylactic options with the patients. And of course, we can continue factor VIII. That means extended half-life or ultra-long half-life factor VIII products, which means less frequent dosing than standard factor VIII, but it's still IV injections. With regular injections, you have a good hemostatic protections, especially in the high-dose prophylactic regimens, and it's a good option for patients with a history of joint issues and a history of chronic synovitis. On the other hand, factor VIII works only if the patient does the intravenous injections. And another option is, if they have difficulties with venous access, he can return to imicizumab after everything is fully healed and there are no ongoing joint problems. This is more convenient for the patients. It's less frequent dosing, and it's an option, especially in patients who have a good joint health. There are new treatments emerging now, and you heard probably about the non-factor TFPI inhibitors. They are licensed now in many countries in Europe, and they are rebalancing the hemostatic system, offering a good prophylactic treatment, but no treatment of acute joint bleeds. The problem with these drugs is that you cannot predict individual response, and some patients have a very good response to these drugs and other patients don't. So it's a moment, because we have no option to measure the effect in the laboratory, more or less a try and error. It's most important to discuss these different options with the patient. And then you consider the patient lifestyle and preferences. You can balance convenience when there's the level of protection, what is needed. You can do it on the individualized joint status of the patients. How important is regular monitoring and reassessment? And in the end, it's a shared decision making with the patient which treatment benefits the most. Always keep in mind that from the standpoint of the physician, you want protection against bleeds and protection of the joints, that joint disease will not develop. So I conclude, and the major takeaways are chronic synovitis can develop even with prophylaxis, particularly after traumatic bleeds or microbleeds. Non-factor therapies alone cannot provide sufficient hemostasis for surgical procedures because they cannot normalize hemostasis completely. So factor VIII therapy is essential perioperatively and postoperatively. Multiple prophylactic strategies available for long-term management are allowing individualization based on patient characteristics and preferences. And from my point of view, shared decision making and regular reassessment can optimize outcomes and quality of life for our patients. Thank you for your attention and for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.